Hello, this is my comprehensive review of Zevtera, or Ceftobiprole. It is presented by me, Dulce Hernandez Delgado. Zevtera was developed by a Swiss biopharmaceutical company that specializes in research and development of drugs targeting severe bacterial and fungal infections. In December of 2024, Basilia Pharmaceutica entered an exclusive distribution and licensing deal with Innoviva Specialty Therapeutics to commercialize Zevtera here in the US. Zevtera was approved on April 3rd of 2024, so it actually just came up on its 1-year approval anniversary, and that's going to be important for future slides to remember. It is also a 5th generation cephalosporin antibiotic, and the cephalosporin class of antibiotics are part of a larger beta-lactam family. These antibiotics have been a pillar to antimicrobial treatments for decades, but just like everything in nature, there's changes, and that new change is the resistance to these antibiotics. The rise of antibiotic resistance has posed a huge threat in modern-day medicine, as easily treatable diseases are now life-threatening. So Zevtera's development addresses these challenges. Treating bacterial infections have been previously developed resistance using the earlier generations of cephalosporins, like methicillin-resistant Staphylococcus aureus and other gram-positive and gram-negative bacteria pathogens that are easily contractable in hospital settings. Disease indications. Zevtera is actually approved to treat 3 different diseases. First off is Staphylococcus aureus bloodstream infections, or we're going to call it SAB from now on just because it's a lot shorter. The second one is acute bacterial skin and skin structure infections, or ABSI. These could be caused by MRSA, MSSA, or Streptococcus pyogenes and Klebsiella pneumonia. The last one could also treat is community-acquired bacterial pneumonia, caused by MSSA, Streptococcus pneumoniae, Haemophilus influenza, Listeria coli, or Klebsiella pneumoniae. One thing to note is that for SAB and ABSI, you could only be used for adults, where for CABP, it could also be used for pediatric populations, and we will be discussing that further in later slides. As for drug description, Zevtera comes in a vial, and it is a lyophilized powder. You do need to reconstitute it with an inactive ingredient, citric acid monohydride, which is the buffer. And then there is also sodium hydroxide as to use as a pH adjustment, and the pH after reconstitution should be 4.5 to 5.5 pH units. The powder for injection is white or yellow to slightly brownish in color, and I wanted to point it out here in the vial. It looks kind of off-white, more yellow, so this is a real-life example. Its molecular weight is 534.6 grams per mole. Its molecular formula is shown above, and its chemical name, which I will not try to pronounce, is also on there. I just thought it would be fun to add that on there. Zevtera's molecular structure is a key contribution on its effects and resistance profile. One key component is its beta-lactam core. Like other antibiotics in the cephalosporin class, Zevtera contains a beta-lactam ring, which inhibits penicillin binding proteins, or PBPs. These enzymes are responsible for bacterial peptidoglycan cross-linking. So by targeting multiple PBPs and gram-positive and gram-negative bacteria, Zevtera interrupts cell wall synthesis, in turn causing cell death. Secondly, its affinity for specifically PBP2A. Zevtera's structure has an oxime side chain, which is crucial in the binding of penicillin binding protein 2A, or PBP2A. The addition of this oxime chain in this new generation of cephalosporins is crucial as PBP2A's ineffective binding is a primary resistance mechanism of MRSA. Zevtera's strong affinity and binding further inhibits cell 1 synthesis, once again leading to cell death. Additionally, Zevtera has a stability against beta-lactamases. Zevtera is modified to resist hydrolysis by some beta-lactamases, particularly AMPC beta-lactamase found in gram-positive bacteria. While the pyrrolidine moiety in its structure provides stability, it does leave it a little bit vulnerable to extended spectrum beta-lactamases, or ESBLs, and carbapenemases, which limits the activity against these kinds of organisms. Lastly, its prodrug form. Since Zevtera's route of administration is intravenously, because it's water soluble, which is converted rapidly into the active form of ceftobiprole. This modification does allow for the effective systemic distribution, as well as its improved bioavailability, as its bioavailability isn't as strong when taken in pill form. Like previously discussed, this is approved for mostly adults with the exception of CABP indication, which can also be used for children over the age of 2. There are instructional warnings for certain populations, which will be discussed at later slides. Like mentioned in 2 slides before, Zevtera is a prodrug that does not require extensive metabolism and is primarily eliminated renally. For absorption and administration, Zevtera is administered intravenously due to its poor bioavailability when administered orally. Typically, it's administered as a 2-hour IV infusion every 8 hours. However, there could be dose adjustments to ensure adequate dosing, which will be discussed later. For distribution, once it's administered, Zevtera undergoes extensive tissue penetration, making it the ideal treatment for skin and pneumonia. Its volume of distribution is around 18 to 20 liters. Its protein binding is around 16%. And for tissue penetration, lungs, skin, and soft tissue show high penetration. However, there is limited penetration in cerebrospinal fluid, making it a poor candidate for meningitis. As for metabolism, Zevtera undergoes minimal metabolism in the body. It is converted into the active metabolite ceftobiprole metocarol, which then hydrolyzes into the active ceftobiprole form in plasma. Its elimination is eliminated primarily through the urine, making renal function a critical factor in dosing adjustments, as it is excreted unchanged, which we'll also discuss later. Its half-life is about 3 to 4 hours in patients with a normal renal function, and for clearance, it clears around 5.2 liters per hour, again, primarily through glomerular filtration. For mechanism of action, Zevtera exhibits bactericidal activity by inhibiting PPPs, which we know are vital to bacterial cell wall synthesis. Targeting multiple PPP, Zevtera effectively disrupts peptidoglycan cross-linking, leading to cell death and in turn bacterial death. I also wanted to point out, so this graphic here is on time-dependent killing. Zevtera does exhibit time-dependent killing, which means that the antibacterial efficacy correlates with the time that the drug concentration remains above the minimum inhibitory concentration during dosing. This is important to note for dosing requirements because studies suggest maintaining the level to be greater than 40 to 50% of the dosing interval for bacterial eradication. Additionally, Zevtera does demonstrate a short to moderate post-antibiotic effect, or PAE, against gram-positive pathogens. Bacterial regrowth is suspended temporarily even after the drug levels drop below the minimum inhibitory concentration. However, this is not the case for gram-negative bacteria, as this effect is minimal, and it does require continuous drug exposure for optimal efficacy. Now we get to move on to dosing and administration. There will be several slides on this just because there are different indications for both adult and pediatric, as well as renally impaired population. Let's begin with healthy adults. For SAB, ABC, and CABP, the dosing amount is the same of 667 milligrams. However, the frequency does change. It could be from every 6 hours on days 1 to 8, and then after that, every 8 hours from day 9. For SAB, you could be treated for up to 42 days. So that is one of the main differences. For ABC and CABP, it is every 8 hours, and you can be treated for 5 days to 14 days. For pediatric patients being treated for CABP, whenever the patients are 12 years of age to 18 years of age, it could be dosed at 13.3 milligrams per kilo every 8 hours. However, for pediatric patients 12 years or younger up to 3 months, it would be 20 milligrams per kilo every 8 hours as well. The duration of use of treatment, could be 7 days to 14 days in this population. Now we get to look into dosing for renally impaired adults. We can start off with SAB. Creatinine clearance is really important for dosing. So if there is 30 to less than 50 milliliters per minute, the dosing is still at 667 milligrams. However, it's every 8 hours on day 1 to 8 and every 12 hours from day 9. If it is 15 to less than 30, you would cut that dosing in half to 333 milligrams, and for the first 8 days, it would be every 8 hours and every 12 hours from day 9, which would look the same for frequency as the previous section. But if there is less than 50 milliliters per minute, including hemodialysis, you would also remain with the half amount at 332 milligrams, but it would be every 24 hours. If we are going to look at the case of ABSI or CABP, for 30 to less than 50, you would still stay at 667 every 12 hours. 15 to less than 30, you would cut that in half the same way. And it would also be every 12 hours. And if it's less than 15 milliliters per minute, including hemodialysis, you would remain with that fractioned dose at 332 milligrams, but you would also make it every 24 hours. This is important to note that we know that with impaired renal function, you are not clearing as well. So if you are seeing that you have a little bit more of a severe impairment, they just want to make sure that they are not overdosing you and that there's no way for you to have any adverse effects. For adult patients, it looks like you would continue to have 42 days for SAB treatment and 5 to 14 days for ABSI and CABP. Dosing for Renally impaired pediatric populations looks kind of similar to what we saw for adult populations. However, there are different requirements in different age groups, and this is also again only for CABP. For children from 12 years of age to 18 years old, if it is 30 to less than 50, you are able to take up to 667 milligrams every 12 hours, 10 mgs per kilo. If it is 15 to less than 30, you would have up to 33 milligrams, which again is cut in half, 10 milligrams per kilo every 12 hours. For patients who are 6 years of age, but less than 12 years old, we would see the same dosing as the previous one. However, whenever it is 15 to less than 30, we do see the reduced or the half dosage given only every 24 hours. For patients 2 years or to less than 6 years of age, you would see also from 30 to less than 50 at 13.3 milligrams per kilo every 12 hours and up to the full dose of 667 milligrams. And at 15 to less than 30, we also see that cut in half volume at every 24 hours. When conducting my research on Zevtera, the only contradictions I found were that patients with hypersensitivity to ceftobiprole or other cephalosporin antibiotics should not take this. I added a table here that I was able to find with all the other generations of cephalosporins, that if any patient is taking any of these or has taken any of them and has had severe side effects, they should probably not take Zevtera, and they should probably look for a different alternative. There are listed warnings and precautions associated with using Zevtera. First one is the increased mortality in ventilator-associated bacterial pneumonia, or VABP. There have been clinical trials showing a higher mortality rate in patients with VABP that were treated with Zevtera compared to other therapies. So this is not an approved treatment for VABP. Additionally, there are hypersensitivity reactions. Serious allergic reactions have been reported in patients with historical beta-lactam allergies, and should take Zevtera with caution. Third, there are central nervous system or CNS effects. CNS adverse reactions like seizures have been associated with cephalosporin use like Zevtera. Monitoring is advised, especially for patients with pre-dosing factors like renal impairment. And lastly, there is a risk of developing Clostridioides difficile associated diarrhea, or CDAD. Just like any other antibiotic, Zevtera's use could disrupt the gut flora, putting the patient at risk for CDAD. Common adverse reactions include nausea, vomiting, diarrhea, headache, and infusion site reaction. There are serious adverse events but are less common, like the hypersensitivity reaction we talked about earlier, the seizures, and the CDAD. Ceftobiprole is an inhibitor of organic anion transporting polypeptides, or OATB 1B1 and 1B3, which I added a little diagram showing what they could potentially look like. Obviously, they don't look like that, but it's a nice diagram. Co-administration of Zevtera with these drugs could lead to an increased plasma concentration of the concomitant drug, so this does potentially enhance the effects and risk for adverse reactions. And this is important to note for the post-surveillance slide as it'll discuss a little bit more of this. Next up is the use of Zevtera in special populations. Firstly, pregnancy. There are no studies of Zevtera's use in pregnant people to evaluate for drug-associated risk or major birth defects, miscarriage, or other adverse outcomes. Animal studies have not indicated any harmful effect concerning pregnancy, fetal development, or postnatal development. However, due to insufficient data, Zevtera is not approved for use in pregnant patients. Lactation. There have been animal studies shown that Zevtera and its metabolites are excreted through milk in very low concentrations. However, there is no data to show this in human trials. For the pediatric population, we did discuss CABP's treatment for minors. However, it has not been established for patient populations from 3 months to less. For both other indications of ABSI and CAB. Dosing adjustments are also needed for pediatric patients, so we also have to keep that in mind. For our geriatric population, there are no dose adjustments necessary for age specifically, but we do know that as we age, we do lose some of our function, and one of those is our renal function. So it is super important to make sure that our geriatric population who is using Zevtera is being monitored and make sure that they are getting the right dosing. Which brings me to my next point is the use of Zevtera in patients with renal impairment. Renal function significantly affects the pharmacokinetics of Zevtera. Dosage adjustments are recommended for patients with reduced renal function to reduce the likelihood of adverse effects. And we were able to discuss that in our dosing. However, I will reiterate that for adults with creatinine clearance, 30 to 50 mL per minute, it should be around 667 milligrams every 12 hours. If it is from 15 to 30, it should be cut in half to 333 milligrams every 12 hours. And if it is under 15 milliliters per minute, it should be the half dose of 333 milligrams every 24 hours. And for the pediatric patients from 2 to 18 years of age, they are necessary, but there are no clear guidelines. The dose adjustments vary due to age and severity of renal impairment, like we went over in the dosing slides. And there is not a lot of data for children under the age of 3 months, I believe. As we have moved through our courses, we do understand that there is certain steps that are needed for drugs to be approved. One of those is having all of our preclinical data, our phase 1 to phase 4 data, and so on and so forth. And I will begin to discuss those. For our preclinical data, there we're able to establish a PK and PD model information and efficacy against resistant pathogens with the help of Monte Carlo stimulations, which I presented a diagram with the basics of it. With the help of the Monte Carlo stimulations, it was predicted that the optimal dosing regimen of 500 milligram dose infusions over 2 hours every 8 hours achieved therapeutic target range for pathogens with MICs less than or equal to 4 milligrams per liter. Additionally, in vitro studies confirmed broad spectrum activity against both gram-positive and negative bacteria, supporting its use for hospital-acquired pneumonia. Additionally, animal studies have shown that ceftobiprole and its metabolites were excreted through milk in low concentrations, like I discussed in special populations. For phase 1 clinical trials, they did demonstrate linear pharmacokinetics with no accumulation during every 8-hour dosing in patients with normal renal function. However, dose adjustments were recommended with patients with moderate to severe renal impairment based on the renal clearance data. In phase 2 clinical trials, ceftobiprole was evaluated for complicated skin and skin structure infections in a double-blind trial in comparison to vancomycin, which is pictured here. In this phase, ceftobiprole showed comparable curable rates at 93.3%, with vancomycin rates being 93.5%. Additionally, for MRSA infections, cure rates were also similar at 91.8 for ceftobiprole and 90.0 for vancomycin. For phase 3 clinical trials, they demonstrated a variety of possible indications. First off, SAB, this trial demonstrated a success treatment rate of 68.9%, comparable to the success rate of daptomycin's rate at 68.7%, with a higher microbiological eradication rate at 82.0%. For ABSI, the trial reported early clinical response rates at 93.1% for Zevtera in comparison to the control drug, which was at 88.1%. Lastly, for CABP, the trial demonstrated a clinical cure rate at 76.4% in adults, making it similar to that of the control therapy, which was at 79.3%. Lastly, we are in phase 4 or post-marketing surveillance studies. If we do remember in the contradictions slides, we did talk about OATP1B and OATP1B3 transporters and their potential adverse effects with co-administration with Zevtera. So after its approval on April 3rd, Zevtera entered a post-marketing surveillance phase to monitor its long-term safety and efficacy. Per the FDA, they were mandated to have a 5-year surveillance of Zevtera to assess the risk, such as drug resistance and adverse reactions due to its co-administration of Zevtera with OATP1B1s and OATP1B3 transporter substances in healthy individuals. We've also learned throughout these courses that post-marketing surveillance studies are to triple make sure that we are being as safe as we possibly can with our new approved drugs and make sure that there are no long-term effects for any populations specifically. Below are my references for my pictures today for this slide, and all of my information was gathered using my monographed report. This concludes my presentation on Zevtera. Thank you guys for watching, and if you have any questions or just want to chat about anything of Zevtera, please reach out. Thank you.